My name is Matt Southwell. I was actually just working it out. I've been a drug user for 29 years out of my 45, so I'm nearly coming up to my 30-year anniversary. For me, it's not something that is a terrible disaster in my life. It's something that's had ups and downs. It's been something that's been very positively enabling in my life. And it was something that I had to keep quiet for 10 years as I was a health service manager running drug services, actually in this area, in fact, in East London, as part of the HIV response. And in 1999, I came out publicly as a drug user and did a documentary on TV about it, and was then rapidly sacked from the NHS, sacked from a 10-year consultancy contract with the probation service because they couldn't employ criminals. And there was a series of consequences that followed on. And for me, what it really highlights is that we live in a society where there are very continuing high levels of stigma and discrimination against people who use drugs. However, and my work with the international network of people who use drugs takes me around the world working with drug users in places like Afghanistan, Russia, Ukraine, and in fact we're going to Mombasa in a couple of months' time. And at that point you start to realise that the scale of discrimination and the problems that we face in this country are minuscule compared with what our community are facing around the world. But as I've travelled around the world, one of the things I've started to do is to look at the way different countries are responding, and to meet with drug users in Portugal, to meet with drug users in Czech Republic, to meet with drug users in different parts of the world, and talk about how their experiences of the policy and practice that they face changes their experience and their engagement with the drugs that they use. So one of the challenges, I think, in terms of reflecting back and trying to set this discourse around this new seven-pillar model of managing drugs policy and practice that I'm going to be presenting today, is one of the challenges when we think back historically is that actually one of the eras where we had some of the best drugs policy in this country was under Margaret Thatcher. And it's, as an old lefty, that's a bit of and having spent a long time demonstrating against Margaret Thatcher, I have to also acknowledge as a drug service manager that the very light style management, the target-driven funding, leaving the Advisory Council on Misuse of Drugs to really guide the strategy of this country without politicians sticking their nose in and messing around with practice on the ground, led to a renaissance in drugs practice in this country, and led to drug user teams like my own team, the Healthy Options team, where half of us were active drug users, welcome to work in drug services, unlike today where we still operate with 2-year drug-free rules for those of us who dare to admit that we've actually taken drugs. So we then come forward a little bit and we start talking with Tony Blair, and we come to this total confusion that Tony Blair seems to bring. Now, Tony Blair came in with this sort of great puritanistic zealousness, sitting down and praying with George Bush about how to respond to drugs policy, and came up with this marvellous idea of having a UK drug czar. As one person said to me at the time, the UK always waits to really see whether drug policy has failed in the US before adopting it. I think we then saw this a about face where Keith Halliwell was I think rather harshly made a fool guy for Blair's policies. He was a bit of an idiot in having met him and worked with him, and I don't feel too sorry for him. But he was asked, he did what he was asked to do by Tony Blair, and when he did it, and it showed that policy was a complete failure, as everybody said it would be from the very outset, he was then condemned, and a new criminal justice leader, this time a probation officer, was brought in to lead our drugs policies. Interestingly, another probation officer renowned for his poor management in the probation service before arriving to lead drug services. And this time we're now not facing a drugs as crime, but drugs sort of crime, sort of disease. And you should definitely have treatment, whether you like it or not. Whether it's the type of treatment that works or not, it doesn't matter, but we're going to tell you what the treatment you should have is. And this stifling bureaucracy that led to a suppression of the innovation that had been so critical to our response to HIV. So the challenge for people who use drugs in this situation was that we were offered a choice between being criminals and being patients. And both of those models frame us as victims. We're not seen as individual human beings who can make informed choices about our lives to define how we use substances in our life. No, we are seen as victims, and absolutely in the new Labour world where you could no longer discriminate against gay people, black people, women, Jews, drug users became a very good, convenient scapegoated population because all capitalist societies need to have a population to blame. And New Labour project was no different than any other capitalist project in that way. But why should we bother? Now, we've just been through the anniversary of 9/11. We're seeing a huge banking crisis around the world. Why bother about drugs policy? Why is it that significant? We're just a bunch of drug users taking drugs. Does it really matter to society to focus that substantially? The problem in the UK is that we have very, very high drug prevalence, partly because of our vibrant youth culture, partly because of ongoing poverty in our country, partly because of high income in our country, partly because of the weather. Now, a huge array of different factors that you might want to attribute to why we have such high levels of drug use in this country. But what it means is if we get drugs policy wrong, it disproportionately affects us as a country. We are the second highest drug using nation in the world, so bad drug policy substantially affects us as a country. So, then we have to pose the question is, well, how badly broken is the system? Now, do we really need to turn around and respond? Well, here we can just turn to the recent European Union review of 10 years of prohibition that took place just in advance of the last high-level meeting of the Commission on Narcotic Drugs. And what that study showed was firstly that prohibition was completely unenforceable. So that actually 10 years of prohibition, 100 years of prohibition, and none of it had made a difference. In fact, drug use continued to go up. Now, you can show with countries with vastly different drug policy regimes, had absolutely the same levels of drug prevalence. So you could start to see that the impact of actually enforcing prohibition was incredibly challenging. Secondly, and this has become an increasingly concern for the European Union, for Latin American countries, is that the actual process of enforcement leads to human rights abuses. And we're now in a situation where we have the UN driving a global policy that infringes the very fundamental principles on which the UN was first founded. And that's creating huge consternation among Latin American and European representatives and positively now even with the US government as well. The fact it also funds organised crime and funds terrorism seems to be just a byproduct of this discussion that seems to be marvellously overlooked. So then we come back to this issue, and I've been a representative for the UK government, as an out drug user, quite interestingly, at the Commission on Narcotic Drugs. Anybody that's been at this place knows that this is a place where we face a global policy impasse. Now, there is such division between the drug war warriors and the progressive public health supporters that we're not going to see substantial change driven at the Commission on Narcotic Drugs. It's just not going to happen. There's too many narco states and other key people there, and I count Russia clearly among that, who are actively blocking change for their own vested interests. So the question then becomes, how far is that single convention a barrier to national change in our own countries? And I think as we start to look around, we see that quite a large amount of flexibility does exist. So let me start to talk to you about my 7 pillars. Now, these are not original, they're pillars that I've seen in other places, but I'm pulling them together into a consistent model. If we're looking at success criteria, perfectly valid that we should still continue to see crime reduction as part of that process. Now, to argue to the general public that they should tolerate huge amounts of crime so that we can take drugs is a non-starting argument and not something that as a member of society I would want to argue for. But it can't be at the expense of public health. It can't be at the expense of human rights. Drug use at the moment is causing social division, not social cohesion, where actually if you look at things like club culture, now these were incredibly uniting factors. We saw in Northern Ireland, young people going out and dancing in clubs together, now very much echoing some of the social change that was then coming in that country. So the idea that drugs are always about negativity, I think, is a big mistake. But my strategy also is one that I think is both affordable, because the current strategy costs a fortune, but actually should result in substantial cost savings. And actually, with the government looking to cut our public sector in pieces, why are we pursuing a policy that wastes so much money in the middle of a financial crisis? And I think the financial crisis may be one of the things that starts to create a tipping point around our drug policy. Just in the same way that gay rights weren't necessarily driven by love of gay people in the first instance. So let's look at these 7 pillars that I'm presenting. The first of which is that we have to hand back day-to-day operational control of drugs policy to the Advisory Council on the Misuse of Drugs. We have to take it away from the rough and tumble of British politics, this ridiculous nature that we have No, the majority of politicians in senior positions now admitting that they've used drugs themselves, but failing to be able to step up to the mark and use that experience in any useful way as soon as they get into power. This is craziness. Now, we actually have politicians who should understand drugs culture because they've taken them. Yet they still want to demonise us and criminalise us as if they themselves weren't part of our community. And that's a very bizarre, that really speaks to the bizarreness of the position that we're in. And we've also got to stop torturing our poor drugs advisors. I mean, I think Professor Nutt here is an illustration, but he is just one of the many drugs advisors that's tried to give advice to politicians, only to be incredibly frustrated that political dogma overrides the science continually. So, what do we need to do instead? Firstly, we have mechanisms like the National Institute for Clinical Excellence that tell us what good practice is. They've done recently great studies on needle and syringe programs, on opiate substitution therapy. No, we should be using these bodies to guide us around the science. We shouldn't be asking politicians to tell us what the science is. We should be asking the scientists and the policymakers to guide us. That's their job. We should ask the Advisory Council on the Misuse of Drugs to take operational control, as Margaret Thatcher effectively allowed them to do in the 1980s and 90s. Of course there should be parliamentary oversight, and we have clear mechanisms. I mean, the Murdochs at the moment are facing the reality of when we have good parliamentary oversight, what can happen? I mean, who would expect the Murdochs to be hauled up in front of a parliamentary committee and for it to lead to such fundamental change? Now, that's the value of a good, effective parliamentary oversight system, and we don't use it enough in this country because of this sort of drive towards an executive style of government. But that oversight should be driven by agreed indicators. So it shouldn't be about a bunch of politicians trying to play with their popularity in the run-up to an election, which is classically when we see most drugs prevention campaigns being launched. It needs to be a preset set of agreements around health, around social inclusion, around housing, around employment, around lack of family breakdown, all of those measurable issues, not this ridiculously loose set of outcomes that the National Treatment Agency is trying to impose upon us all at the moment, so that people understood from the start what the policy was trying to achieve. And then we should measure it on the basis of, does the policy achieve the outcome? That should be the measure, not how popular does a politician need to make themselves, or are they trying to get over some latest political embarrassment. The second measure, I think, is unsurprisingly to pick up on the Portuguese-style model of decriminalisation. I'm not going to spend lots of time on this because it's I think, been well described. Firstly, it ends the terrible consequences of criminalisation on individuals. One of the members of my local drug user group, whose whole teaching career potentially is up in the air because of being arrested at a fun fair for taking drugs. A whole career thrown down the drain before it's even started. It would allow us to refocus police resources on things that really matter, like organised crime. It would allow us to enhance police community relationships, as was so nicely demonstrated by the skanking police officer at the recent Notting Hill Carnival. And importantly, what we've shown from Portugal is that actually when you take the pressure off around criminalisation, treatment uptake goes up. And in fact, in Portugal, treatment uptake has doubled. Now that's an incredibly significant outcome. So the third factor, and this is drawing on a Dutch model, is that we remove pressure from illicit drug supply networks. And what the Dutch have done, and particularly the Amsterdam City Council have done, is to withdraw routine targeting of drug suppliers. So they do not make an operational priority to go after drug suppliers. And I mean drug dealers here. I'm trying to use non-discriminatory language to describe people who play a reasonably normalised function within our community. They're like vegetable sellers to you, are our drug suppliers to us. So, no routine targeting of drug suppliers, clear rules that state, around schools, around public sensitive areas, there will be no drug supply whatsoever. And in Amsterdam, they have a police unit that clamps down rapidly and hard on anybody that strays away from that social agreement. And that then allows us to see a rise up in consumer choice, because consumers will then prefer to not buy off organised gangs, but will instead look to go much more for a consumer quality service. The next issue, I think, is to normalise and improve the treatment of services. We need to have a range of treatment models, from the medical to the shamanic to the psychosocial, whatever it takes to help people change. We need to be client-centered in our treatment outcomes. We need to respect that people may choose drug-free outcomes, may choose to be on methadone for the rest of their life, or may even choose to carry on using drugs illicitly while also being on opiate substitution therapy. And all of that will help reduce stigma and discrimination, because 80% of people who have problems with drug use at the moment choose not to enter services through fear of judgment. That's in the UK. And so we have to actively advertise to say we are not judgmental in our services. We actively want to support you. We're not here to demonise you, because the vast majority of drug users at the moment fear that that's what will happen to them when they come into services. So we also need to continue extending and enriching our harm reduction services, and this is our big UK success story. This is what DFID goes around the world promoting, which ironically we fail to even implement in our own country or sustain in our own country. The success of needle exchange and methadone, the huge innovation of organisations like Exchange Supplies that have been so creative in their responses, and the whole range of new harm reduction, whether it's crack pipes, pill testing, consumption rooms, that all help us manage the consequences of even the hardest parts of the drug scene. We also need to look at how we tackle short-term drug-related offending. And here I think we have to recognise that we have two very different populations. Half the population are people who get into crime because they have drug dependency issues. Now, this group respond incredibly well to drug treatment and to basic information, because actually it was only drug use that got them involved in crime in the first place. However, the other 50% were already hardened criminals, whose intensity of offending dramatically goes up once they become dependent on drugs, but even when they stop taking drugs, they tend to still return to their old patterns of offending. So this group need a whole different array of interventions, and we know they're incredibly complex to manage. Now, and these are a challenging group of people, but to describe them purely as drug users is to really misunderstand who they are as a group. And we really have to ask, what are we trying to achieve with this group? Are we trying to stop crime or stop them taking substances? And I think we have to get to the reality that the priority is to stop them committing offences rather than getting obsessed about whether they take drugs or not. Finally, in my model, is the issue of fostering healthy drug community norms and systems. What we know is that drug systems and drug networks under pressure fragment, and they are associated with far greater levels of risk. So the first thing we need to do is take the pressure off those communities, and all the suggestions I've made are ways of easing back the pressure. This would allow an empowered community of drug users, where the natural functions of community, such as mutual aid, peer support, advocacy, the establishment of community rules, would all kick in. Just in the same way that strategies against drink driving, strategies against sharing of injecting equipment, strategies in favour of drinking water while taking ecstasy have all taken hold as cultural norms. And one is to reduce the pressure on the drug scene, and the other is to support the organising of drug users, who can then drive forward these changes. So here are my 7 pillars. I think these have all been done in different countries, so I'm not proposing anything that's not been done and tested. What I'm proposing now is to bring it together and say there is no excuse not to do this now. All of this can be done within the current drug conventions. Thank you very much.